Here my topic is the use of near-infrared spectroscopy to help determine optimal resistance training intensity for improving peripheral arterial disease. So this is my topic that I selected for my research question based off of the article that I read this week. So just kind of overall, the research article that I selected to read this week, it was not necessarily the outcomes of the comparison groups as well as interested in, more so the instruments that were involved in the investigation. So this research study looked at a pre and post comparison over a 4 month span of patients with peripheral arterial disease. And it was comparing different types of therapies. So the first therapy was your interventional group with the exercise intervention. So they were going through a safe exercise intervention with a personal trainer for 4 months versus the other group that they were comparing outcomes with. They completed a revascularization of the occluded peripheral artery. So what the intervention was is they went through 4 months, a pre and post within those two interventional groups, and they compared it with a 6 minute walk test. And what they used to compare exercise tolerance to the time of what you call intermittent claudication, when the lower limbs become ischemic and you have that cramping sensation, they use a device called near infrared spectroscopy. So that's called NIRS. So what that is able to do is it's able to collect real-time metabolic biomarkers of oxyhemoglobin, deoxyhemoglobin, and then therefore the differential hemoglobin levels of those O2 saturation components of the working limbs. So that is what I was interested in here. There is a device that is able to measure that for a internal objective marker when it comes to exercise prescription for those with peripheral arterial disease that struggle with exercise tolerance due to that intermittent claudication. So kind of a little bit further into how this helps expand my current understanding of research in this area that formulated my research question. So current research that evaluates in the world of resistance training as a therapeutic exercise component for peripheral arterial disease, they've compared different types of intensity of 1 rep max in resistance training interventions to see what was better for improving exercise tolerance for peripheral arterial disease. So most of them, kind of like this one article by Hansen et al. In 2019, they compared a light intensity, which was 30% of their 1 rep max, compared to a heavy intensity, which was greater than 70% of their 1 rep max for resistance training exercises over a 10-week period. But both intensities required 4 sets of 8 repetitions. And we know, kind of in my second bullet point, with our Essentials of Strength Conditioning, with our National Strength Conditioning Association textbooks, their pre-reference charts, lighter intensities require greater volume, especially greater than 3 sets of 8 or 4 sets of 8, as opposed to higher intensity resistance training. So the only difference they had was changing the intensities, but they didn't cater to the fact that the lower intensities required a greater volume to elicit a stimulus versus those greater intensities. So it was shown that greater intensity resistance strength training was more beneficial. But did that really answer that question if we weren't eliciting the correct amount of volume for the lighter intensity group? And also, there's other evidence out there that higher resistance training intensities lead to greater arterial stiffness, which also worsens endothelial function, which is already impaired in peripheral arterial disease. So that kind of goes to my research question here. So we have a mix of both. We have the utilization of NIRS device to be able to measure an internal objective marker that could guide the amount of volume for each set based off of different intensities of resistance training. So rather than having a 30% versus a 70% and giving them both the same amount of volume, because there was no ideal for the internal objective markers, now we can utilize NIRS to be able to let the oxyhemoglobin, deoxyhemoglobin, we can create a threshold within that intermittent claudication of the O2 saturation within the working limbs to make that the marker. So rather than saying we're going to do 3 sets of 8, now we can actually have an internal objective of whatever percentage of O2 saturation that might lead to intermittent claudication or within a threshold of that. And we can compare intensities of resistance training. So like that other study by Hansen et al. Have 30% versus 70%. But rather than doing 3 sets of 8, now both groups can do as many reps as they can of those resistance training exercises until they hit, say, 5% of a threshold within what they would experience intermittent claudication. So they wouldn't have to experience so much discomfort for that. So what I want to do is, can the use of near infrared spectroscopy help determine the optimal intensity of resistance training for peripheral arterial disease? Right. So that kind of leads into my assumptions with this, right? My hypotheses. So my first one is the volume measured in total number of repetitions achieved will be achieved greater in the lower intensity resistance group compared to the high intensity resistance training group, right? So rather than giving them a go ahead set volume of 3 sets of 8, let the lighter intensity actually achieve this volume that it is set for and it should be able to achieve to be able to elicit that stimulus of more of a muscular oxidative adaptation like it needs to. My second assumption here is lower intensity resistance training with the appropriate volume will help achieve a more direct stimulus to improve exercise tolerance in peripheral arterial disease. Exercise tolerance is usually, a lot of the studies do the 6-minute walk test. When it comes to textbooks of cardiac rehab, AACBPR guidelines and ACSM guidelines, usually you want a symptom limited test, which in this case, I think most ideal could be a low incremental cycling test. So then basically the intensity of the cycling cadence will increase over certain units of time, like whether 1 minute or every 2-minute stages. And this is kind of my references that I was using for the my background of why I was kind of asking these questions based off the current gaps I was detecting through the literature that wasn't directly answering to the best of its capabilities that research question to be able to best guide patients with peripheral arterial disease with proper resistance training to best benefit exercise tolerance.